Hello, and welcome back to Fertility Fact or Fiction, our show every week where we share with you the latest news in the infertility world and try and help you make your infertility journey better. I am your host, Dr. Rahid Victory, and I am here with my trusty friend Tarek, and we are going to be presenting tonight on a hot button topic, which is the use of letrozole for frozen embryo transfers and whether or not this is better than doing a conventional or a natural cycle. So we usually allow everybody a little bit of time to jump on and to get oriented to everything. So grab yourself a cup of tea or coffee. If you're logging on Instagram, make sure that you follow us. And if you are on YouTube, make sure you click that subscribe button and notifications. And that way you will know when we put out new videos. And there are lots of new videos coming. So hopefully you guys can watch that. If you haven't had a chance to check out our newest video on unexplained infertility, for those of you that are suffering with that, it's an awesome video, details everything you need to know about what works and what doesn't work, so check that out on YouTube. Okay, so tonight we're going to talk about two studies actually, looking at letrozole, and there's a third study plus all the other ones I researched for you if you want to look at those too. And this is on whether or not using letrozole to prepare your endometrium is better than doing either a natural cycle or a conventional cycle. No volume? Oh. Okay. So the first study, you can pull it up if you want to there, is called Systematic Review, Update, and Meta-Analysis of Randomized and Non-Randomized Controlled Trials of Ovarian Stimulation versus Artificial Cycle for Endometrial Preparation Prior to Frozen Embryo Transfer in Women with PCOS. So the first part of this is, does the letrozole work better in women that have polycystic ovarian syndrome, specifically to get them ready for their frozen embryo transfer? So in general, there are three ways to get the uterus ready. So number one would be natural. You don't give the patient any meds, you follow their cycle, you wait for their LH surge, and then you can time the embryo transfer to be anywhere from 5 to 7 days after their LH surge, because they've researched that, and it actually doesn't make any difference. Option number two is to go ahead and do a modified natural cycle, which is using something like letrozole to kind of stimulate the lining to grow and get the eggs to kind of, mature and release. And it's particularly useful in someone with something like PCOS where they're not ovulating on their own. You can then, again, follow the natural cycle, or you can trigger it. And whether or not you add in progesterone or not is obviously up to you and your center. The third way is what's typically referred to as the hormone replacement cycle or hormone replacement therapy cycle, where you're going on estrogen until your lining is thick enough, and then you're going on progesterone and so on. So there are concerns about using that for two or three reasons. Number one, you're getting much higher levels of estrogen than are physiologic. And so the question is, do those supra-physiologic levels of estrogen act detrimentally in the cycle to either reduce your chances or to make it complicated in the pregnancy? Things like preeclampsia, IUGR. These have been associated with high levels of estrogen at the start of the cycle. The second part of it is that it may be that these hormone replacement cycles or hormone replacement therapy cycles are actually reducing your chances by causing more inflammation than in a natural cycle. And so the question is, are you getting less of a chance because estrogen can be kind of pro-inflammatory, and that's also not ideal. And the last possibility is if you have endometriosis or adenomyosis, obviously the hormone therapy cycle with much higher levels of estrogen is going to overdrive your adeno and your endo, and that's never a good thing when you're trying to get pregnant. So with this study, basically what they did was they took a whole bunch of different articles, they analyzed them, and I'll show you their sheet for that. And then they looked at what they had. So here you can see they started with about 139 from from PubMed, 264 from Embase, and the Cochrane Library had another 100 studies. They went through them all. They removed 339 of those because of duplicate records. They screened through about 356 that were left over. A bunch of them were not related to women with PCOS. They ended up at the end of all this with just the 9 studies you can see in the bottom of that table. Are you on the same page there, right? So then the next thing that they did was they analyzed the live birth rate. So I'll just blow that up for you to see. Whoops. Sorry about that. And I'll grab a pen here so you guys can see what I'm seeing. Okay, so if you look down here, you can see that the overall results here, when you're comparing stimulated to non-stimulated, showed a significant improvement in the live birth rate between the stimulated and the HRT cycles. So when they did the letrozole stimulation or even an HMG stimulation with shots, you had a better outcome than you did when you took the hormone replacement therapy. Now, in this group, you're seeing about an 11% increase in live birth, which is where that 1.11 number comes from there. 1.11 means that you have an 11% increase above normal for the live birth rate. So that obviously was kind of helpful, and they were very pleased with that. So they said this is something that obviously is beneficial. When they then went into the next part of this, they looked at ongoing pregnancy rates. And in the ongoing pregnancy rates, as you can see, there was no statistically significant difference. So live birth rate's higher, but they weren't seeing a big difference in the ongoing pregnancy rate between these two. When they skipped into miscarriage, however, you do see quite a significant change overall, with a huge decrease of about 40% in the group that is using either stimulation or letrozole compared to the groups that are using hormone replacement therapy. And that's this little diamond down at the bottom. It's on the left side of the line, as you can see. And that is at the 60% mark, which means you're getting a 40% reduction in the risk of miscarriage, which is huge. So this makes a big, big difference. And this is highlighting the fact that all that estrogen stimulation is probably not ideal when you're doing these types of procedures. Specifically with regards to letrozole, which you can see here, it's very, very significant. It's actually at 46%. So it's even higher than the group that is just, overall mashed together with the patients that were stimulated. So basically, at the end of all this, what they said was that the outcomes were much better because of the fact, and you can stop the link there, for the fact that the letrozole group is getting a much higher success rate in terms of live birth and a much better outcome in terms of miscarriage when they're taking letrozole versus doing hormone replacement. So again, this is in the PCOS group. It's obviously quite important to get a good effect here. And so we want to make sure that in the PCOS women, we are doing our very best for them. And this obviously is demonstrating that your best approach to that, and this is based on multiple trials, 9 to be exact, is to demonstrate that you can use letrozole to good effect. So they looked at some other things like cycle cancellation rate. They showed that there was no difference. They looked at ectopic pregnancy rates. They said there was also no difference. And they also looked at the outcomes in terms of things like, high blood pressure, diabetes, and so on. And none of those were statistically significantly different. So it's just as safe to use the letrozole, but you're getting much better outcome in terms of miscarriage. And that's, again, hugely important for everybody going through this. So what about the patients, obviously you're all asking, who don't have PCOS? If you can flip back on again. So there's another study out there, very recent, called Retrospective Cohort Study on Preparation Regimens for Frozen Embryo Transfer. So these guys basically did the same thing, and I'll pull it up for you. So the first thing you can see down here at the bottom of the graph there is the demographics. So they had a letrozole group, a natural group, a group that had stimulation with shots, and then the programmed group, which is the take your estrogen, take your progesterone. So no significant differences in any of the categories here in terms of, what they were actually getting. from the age or from the oocyte pickup when they did their age, short cycle, long cycle. It was all essentially the same. There were no statistically significant difference. Okay. So when they looked at the table 3, the pregnancy outcomes, you can see there's 830 in the letrozole group for embryo transfers. 32% had a live birth delivery. Natural cycle had 1,253 live births, 4,565 embryo transfers, 27.4%. FSH and OI was 32.5, and the program was down to 16.6. So huge decrease when you were doing the program cycles with estrogen and progesterone compared to what you were doing when you got either letrozole or a natural or you took the shots. So then they went down and they adjusted, comparing everybody to letrozole. So if you look at the bottom of the page there, you can see that the live birth rate adjusted for letrozole was not statistically significant compared to natural or the stim, but compared to program, you have a 92% increase in success when you're using the letrozole. So there's nothing wrong with doing the natural cycle, and there's nothing wrong with doing the stimulated cycle, but it's way easier to do the letrozole cycle than to do the stimulated shots again. And this is showing a 92% increase. Also, when they did the unadjusted assessment of this, and that's adjusting for confounding variables, things like were you a smoker, was your weight an issue, was your age an issue, they did see that the letrozole was better than natural in the unadjusted, and it's awfully close to the margin even in the adjusted. So you can see there it's 1.12, but then its margin is 0.95 to 1.34, and I can highlight that for you so you know what I'm talking about. That's right here. So essentially in that group, there's this trend or tendency towards it being significant. What happened when they looked at the next stage of this? They looked also at whether your cycle was short or long. And you can see that there is, in the natural cycle, most people were about 28 to 35 days. The effect of the letrozole, there was a 44% increase in the number of patients that fell in that 28 to 35 day range. Compared to programmed, you're seeing a huge increase where patients fell in the normal range, because that's a 4.56 fold. So that's almost 350% higher. And then 130% higher for the long cycles compared to program. So a little bit of a difference in there, but essentially it's showing you that the control of the cycle may be better when you are doing this with letrozole than it would be without. So bottom line is there are also multiple other studies that have demonstrated essentially the same thing, to show at the end of the day that you are going to get a much better success rate. There's also one more study called Comparison of Perinatal Outcomes of Letrozole-Induced Ovulation and Hormone Replacement Therapy Protocols in patients with abnormal ovulation. So this is going back to the PCOS patients, and they looked at this. And essentially what they said here is that for women with abnormal ovulation, the pregnancy and perinatal outcomes of hormone replacement therapy or letrozole OI protocols are reassuring. Both of them are safe. So you're not getting any detriment in the outcomes from the standpoint of what's going to happen to your pregnancy or your baby by going to letrozole, but you are getting a decrease in miscarriage. You are getting that increase in live birth. So is it worth it for people to be on letrozole? We've been using this now for about 2 years in our frozen embryo transfer protocol, and our success rates are the highest we have ever seen them. It works amazingly well. You get great control. We do still need to give some patients a little bit of estrogen, and that's to help get their lining to thicken a little bit. And you have to monitor for follicular growth because it can stimulate you to produce an egg and release it. But as long as everything goes smoothly, we are getting amazing quality lining, getting very high matrix scores. For those of you that believe in matrix, we have had very, very few miscarriages and losses, and we are getting phenomenal pregnancy success rates. So very strong advice from us to really strongly consider using letrozole as part of your cycle. When you go to a center where they just want to pack you full of estrogen, 12 milligrams, 8 milligrams, that is definitely not the ideal approach because that is pro-inflammatory and not necessarily good for your lining. You have to remember, in a natural scenario, your estrogen peak is not getting anywhere even remotely close to the levels it's getting at when you're taking 12 milligrams of estrogen a day. And so that can't be natural and maybe not necessarily is as good for you as it is when you take a more natural approach with something like letrozole. So, fact or fiction, it is a fact. Letrozole can be the thing that will make the difference for your cycle, both in reducing miscarriage and in increasing your success rates. I think you should all at least strongly consider it, talk to your REs about it, and see what they have to say for your specifics and your case and point. Hope you enjoyed that. Make sure you click the like button and subscribe on YouTube and follow on Instagram. And we're going to take your questions live now.
How long should I use Vizam before egg retrieval? After the completion, should I wait to have my period before starting IVF or go within 5 days of completion? 2 doctors gave different opinions.
So the study on Vizam showed that you should use it for 3 months prior to your IVF. And as far as how long before to go off, it's very variable because they're probably going to wait for your period, and it's variable as to when you will start your period. We actually roll our patients off of Lupron for frozen embryo transfers with letrozole by waiting the 12 weeks for the Lupron to wear off and extending the letrozole for an extra 5 days. And then we just see their lining start to grow. So that's typically been our protocol. There's no reason why you can't do something similar on Vizam. So just talk to your RE about that. But the timing of stopping it relative to when you're going to start your period, everybody's different. So there's no way to gauge that exactly beforehand. But you definitely should be using it for 3 months ahead of time. We reviewed that on the show probably about 2 years ago. We are going to go through all our YouTube videos and name them a little bit better so it's easier to identify what's what. But we will get that up there for you so you can identify which one the Vizam one is.
Folic acid versus folate. Why one over the other? You suggested NFH but couldn't find in USA. Could you suggest another? Does folinic acid interfere with patients with Hashimoto's hypothyroid disease?
No, folinic has no impact on your Hashimoto's, but if you have methyl tetrahydrofolate reductase enzyme, the MTHFR, then if you have a mutation in that, either heterozygous or homozygous, the recommendation is that you consider taking folinic acid. It is controversial, but the naturopaths all say that you should take the folinic acid rather than the folic acid. It doesn't really matter what brand you use. Choose whichever one you want and just grab that. They're all going to basically function the same. I'm surprised that NFH isn't available in the US, though. I would have thought that'd be a huge market for them. Yeah, you can use either, any other brand is fine. There's no, we don't promote one brand over another. So whatever you guys want to use is fine.
What role does the thyroid play in fertility?
Oh boy, it plays a huge role in fertility. So remember, your thyroid is the master control center for your entire body's metabolism and to some extent a little bit of a control center for some hormonal function. So if your thyroid is not functioning properly, it can really throw everything else, out of whack. And so you need to make sure that you know exactly what is going on with your thyroid. The Endocrine Society has recommended that in the first trimester, your TSH be less than 3, and in the second 2 trimesters, your TSH be less than 2.5. And then we recommend, based on lots of studies out there, that you make sure that your thyroid antibodies are low, because women with thyroid antibodies have a much higher risk of miscarriage or failure if they're doing fertility treatment. So that's also very, very critical.
Glad to know this information. I'm transferring next week. I have PCOS and took Letrozole CD 3 to 7.
Awesome. Great. You did the right thing. I'm really happy for you. Well done. And whoever's taking care of you obviously knows what they're doing, or maybe watches our show.
I bet you they watch our show. That's my confidence. Okay, I got a big one,
Okay.
and I mean humongous.
That came out sounding so well.
No, it did not. It did not.
Tarek has a large question for us. Go ahead.
Hi, Dr. Victory. I have a question about progesterone during an FET.
Okay.
What are the ideal numbers for a transfer and after? I'm a little confused. I have had 2 embryo transfers, one natural with 5,000 IU trigger PIO 1 mil every other day, 300 milligrams endometrium with letrozole, and 5,000 IU trigger also PIO 1 mil every other day, 300 milligrams endometrium.
Okay.
Lining, first transfer 8 and second 13.
Okay.
My progesterone numbers were both around 60 for each transfer.
Yep.
First question out of a statement here, is that too high?
No, well, it depends what units. If it was 60 nanograms per mil, yeah, that's way too high. If it was nanomoles per liter, no, that's normal. That's what you're looking for.
They also both increased to over 60 and then dropped after negative beta into the 20s while I remained on progesterone support. People keep saying how there is no such thing as too much progesterone.
Oh,
Is that true?
no. There's definitely too much progesterone. If your progesterone is too high, you're on birth control. You can over progestinize your lining for sure. Anybody saying that you can't have too high a progesterone level doesn't know what they're saying. That's absurd. I mean, the main part of the birth control pill that actually functions to prevent pregnancy is progesterone. The estrogen's just there to prevent you from bleeding. So if you get too high a progesterone level, you are over progestinizing your lining, and that is not a good idea at all. So you want it in that sweet spot between 40 and 100 if you're using nanomoles per liter, and between 10 and 30 if you're using nanograms per mil.
She continues to say, I notice I get a lot of cramping and discomfort the higher my progesterone is, which worries me that it's harming implantation. One has a euploid embryo. How can I keep my progesterone at a good level without it increasing so high and quickly? Should I be worried that it's not managed properly, harming my chances of success? How can I advocate with my doctor to keep progesterone in a healthy range as we start another FET? Thank you very much.
Yeah. So you can advocate by advocating. I mean, just speak for yourself and say, look, I want my progesterone levels to be optimized. Now, I'm not sure they're not optimized for you because, again, I don't know what units you're using. But if you are in the nanogram per mil, that's like over double or triple the level it should be. And that's way too high. So I would just say you want less, progesterone. Maybe take 2 endometrium a day instead of 3, and maybe cut the progesterone and oil in half. We actually adjust acutely all the time. So we give our patients 3 days of progesterone. Then we monitor the development of their progesterone level. And if their progesterone level is normal at that point, we keep it the same. We do their transfer. And then the day after their transfer, we check it again just to be sure. So that's kind of the level of sort of observation you want. And if we adjust their progesterone level because we do find it's too high or too low, we recheck it like within a day or two, or even on the day of transfer, because you may need to readjust it again.
I got
Another doozy?
It appears so.
Okay.
I'm not sure if it's one question or
You're
a bunch of
scrolling a hell of a lot, man.
It's one. So if it's more than one question, we'll go to someone else afterwards. But
Okay.
we'll start with this.
Okay.
Okay. Oh, here's
a short one.
Yeah.
Okay.
How do we test for MTHFR? Is that part of Fertility's immune testing, or should it be tested separate?
It's not part of Fertility's immune testing. I think they do it as part of their thrombophilia screen, but almost any lab will test you for your MTHFR status. So normally you don't have to leave your country of origin to find out if you're MTHFR positive. Most labs are capable of finding that out. And if you're heterozygous, probably just baby aspirin and the folinic acid, although some people want to still take heparin as well. If you're homozygous, we would definitely have you on the heparin also. The big one. Okay.
Hi, Dr. Victory.
Hello.
I have a question about estrogen.
Okay.
I'm 45,
Okay.
and my estrogen rises to about 500 or 600 around day 8 when I ovulate.
Okay.
My last FET, we used letrozole to keep my estrogen low and build a good lining.
Okay.
However, my estrogen was only at 45 at embryo transfer and rose to 735 5 days after embryo transfer. I did not use any estrogen support. I'm curious, what are the optimal estrogen numbers and when do you start supplementing with patches, not pills, as they raise my estrogen way too quickly and too high? How do you like to see estrogen behave in a natural modified letrozole cycle? And when do you step in to improve them?
So your estrogen levels are going to be low when you're taking letrozole because letrozole blocks estrogen. So, like peripheral estrogen creation. So, it's going to be much lower than normal. Now, there is one study, although it's a very, very small study, which showed that if your estrogen levels are too low, that's not ideal. And several months ago, we reviewed a study that showed that if your estrogen levels weren't kind of in the ideal range, that it did impact your implantation success. So you wanted a little bit, not too much, not too little. We don't focus as much on the estrogen levels as we do on your lining. And obviously, they're correlated to some extent together. So, what we really monitor is your lining. If your lining is not getting thick enough after about 10 days, we do start a minimum amount of estrogen. So I'll just use 1 milligram of estrase initially to see how things go, and then I'll bump it up by another milligram if they're still not thick enough. And that seems to usually do the trick, and that should be all that you need in order to get a good result. Thicken your lining and still keep your estrogen levels in a reasonable range. So that's what we're doing, but don't focus on the estrogen level. As long as there's a little bit of estrogen there, you're fine. It's the lining that's the important part. And you don't want your lining too thin, so less than 7 is considered thin, and you don't want it too thick, and that's basically over about 13, 14. We try and keep it even less than that. We want to be under 12.
Hello, Dr. VNT. Speaking of fertility, thank you for last week's show, packed with info.
Oh, good.
What is the treatment after testing, antibiotics, steroids? Would this help find about implantation fail?
So once you've done your fertility testing, they'll give you recommendations on what to do. So normally it's take these antibiotics and then you have to retest. If it's an immune problem, you've got to actually figure out what the immune problem is and then find the appropriate therapy for whatever your special issue is. So sometimes it's doing lit therapy, sometimes it's doing IVIG, subcutaneous IG, intralipids, tacrolimus, steroids. There's all sorts of different approaches to this. Plaquenil is being shown to be beneficial. So there's a lot of different things that can go into it, which will help you, but you got to figure all of that out. And it'll be in your fertility report. Lit therapy can be quite expensive, so not everybody jumps into that, but it's an option. It's really expensive.
Best way to thicken endometrium?
Vitamins would help. Aspirin will help. Vitamin E is really good for it. Vitamin D and C. You can use Viagra, that will help, and then obviously mainly estrogen, right? So if your lining is really thin, estrogen. Additional kind of more wacky stuff, PRP, which we've started using fairly recently, and GM-CSF or Neupogen. All of those have been shown to thicken the lining successfully in patients with a thin lining.
Do you recommend progesterone until the end of the first trimester or longer?
Okay. So I'll give you my my protocol, and I'll explain why I use my protocol. But I don't have proof for my protocol. I want to freely admit that. So our protocol is that we use vaginal and progesterone and oil. There's proof for that. And we use that until 12 weeks. So once we hit 12 weeks, we stop the progesterone and oil because you shouldn't need it after that. And we cut the dose of our vaginal progesterone in half at 12 weeks, but keep our patients on it till 36. So some of you are going, oh my God, that's crazy, I'm sure. So the reason for that is infertility patients do have a higher risk of preterm labor, and progesterone is known to prevent preterm labor. So I'm using it to prevent the preterm labor. So we kind of transition from pregnancy establishment support to pregnancy maintenance support. And so we keep our patients on it till into the third trimester, just a few weeks before they're due.
Who is letrozole FET protocol indicated for?
Anybody that has ovaries that can function and produce an egg, it will work for. If you're menopausal, it's probably going to be a little bit less useful. But if you're not menopausal, you're going to get a benefit from taking letrozole. So at this point, the data suggests that it's at least as good, and in many instances better, depending on which study you look at, for all patients. And certainly in the PCOS population, it's pretty clear that it's an advantage.
Endometriosis, but also have a thin lining when treated with estrogen shots. Next steps.
If you have endometriosis, the last thing on earth I would want to give you is estrogen shots. So I'd probably start with letrozole, and then just a minimum of vaginal estrase or any other vaginal estrogen, support that you can get. Very, very little, and see how your lining thickens. If it's still not thickening, you probably need testing to figure out why your lining isn't thickening, whether it's infectious, it's scarring, hysteroscopy, PRP, the Viagra, all the things we talked about a moment ago that can help improve the thickness of your lining.
Are estrogen levels of 1,500 to 2,000 too high prior to FET?
Depends on which units. Not if it's the Canadian metric units. If it's American units, yeah, that's very high.
What does ubiquinol do? You recommend it for IVF prep?
Yeah, so ubiquinol or ubiquinone are both known to assist with mitochondrial function. Mitochondria is the energy factory for your cell. So all of our cells use something called ATP in order to do all their cellular activities. It's like gas for your cell. And the gas is coming from the mitochondria, which is your petrocan station or your shell station, or whatever you want to call it. So in order to keep those stations running smoothly, they need to have coenzyme Q10. So if you're taking CQ10, which is ubiquinone, you're going to get improved energy function inside the eggs, and that is supposed to translate into better embryo quality. No one knows for sure if it does, although the studies do seem to suggest the outcomes are better. One of our biggest videos is on CQ10. It's on YouTube, and it says CQ10, what they don't want you to know. So check out that video. It explains it all there.
Way to go with the Iranian-speaking viewer last week.
Oh, that's hilarious.
When do you start baby aspirin before FET? My RE started me on it after.
Yeah, so in my mind, that doesn't make sense. The whole setup is to get everything in balance before you put in the embryo. If you start taking stuff after you've put in the embryo, like your body has to make all these adjustments. Embryos don't like going into an environment where they've got to constantly adjust. So you want to put the embryo into a nice stable environment. So we actually start our patients on it way before. So, 5 days before, a week before, 10 days before, 2 weeks before, long before.
On average, how much does AMH decrease post-bilateral cyst removal? The cysts are 3 centimeters.
It depends on which study you read, but to be honest with you, much more importantly is it depends on what kind of cyst and who's doing the surgery and how they're doing the surgery. So you get surgeons that get panicked because they see some bleeding from the ovary and they start burning everything. Well, you're going to do a lot of damage to the ovary, and that's been shown to have a huge impact on your AMH, your antral follicle count, ovarian reserve markers in general. If you get someone who's super delicate, they know the fact that the ovary does not need to be cooked to death after the cyst is removed to stop the bleeding. They're patient, they're careful, they're stripping the cyst out, and they're not kind of de-roofing the ovary, you'll get a very good preservation of the ovarian function. So it very much depends. A 3 centimeter cyst is not very large, although if you're going for surgery for a 3 centimeter cyst, I'm going to assume it's an endometrioma. Forgive me if I'm assuming incorrectly. If you're going for endometriomas in and of themselves reduce your antral follicle count and your ovarian reserve. So getting rid of them is helpful, but they themselves have already done some damage. So I do advocate for removing them. Not everybody does, but I believe it makes much more sense to get rid of them while they're small. So you're probably doing the right thing. But there's no way to give you a percentage change because everybody's different and it very much depends on the surgery and so on. Majority of studies showed about a 1 nanogram per mil change, anywhere from about 0.7 to 1 nanogram per mil change in your AMH for up to a year after the retrieval is, the cystectomy is done. But again, it's very patient and procedure dependent.
Dr. VNT, how to tell gender for fraternal twins? Do I have to wait?
How to tell
gender of fraternal twins? Do I have to wait?
You could do NIPT testing, I guess. So you would know when you get to 9 to 10 weeks. So that'll tell you. You'll either see boy or girl or both. But that's the only way I can think of. There are some ultrasound techniques that people think makes a difference. They have not been validated in studies yet, so we don't know.
Is clipping of the Hydrosalpinx tube necessary for IVF?
Is clipping of a Hydrosalpinx tube necessary for IVF? Patients with Hydrosalpinx have a 50% reduction in their success rate with IVF. So in my opinion, you should never have them clipped because that's a very easy way to cause infection. You should be getting them removed, which will very significantly improve your outcomes. So we always remove them for our patients, but clipping them, you've now got a block. So Hydrosalpinx is fluid in your tube. You know what? This is a good one to draw.
Yeah, let's do it.
All right. Pull up the draw.
I think watching you draw is actually like watching people draw with the stylus is a soothing thing for the eyes.
Okay, here we go. So your fallopian tube.
You didn't share.
Oh, I didn't share it right. Sorry. I'm going to share my fallopian tube drawing skills with you.
I'm ready.
Okay, you got it?
Yep.
Okay. Oops. So here is your handy dandy fallopian tube, which normally looks like that. Okay.
It's a great rendition.
If you have, you're so dead. If you have a Hydrosalpinx, then the tube is really swollen like this, and inside here is water. Okay. The problem is, in order for the tube to retain water, what's actually happening is it's blocked here and it's blocked here. And so it's retaining water because the water can't. So if they want to clip it, all they're doing is adding another block somewhere here or there or wherever they're going to clip it. That doesn't do anything because all you're creating now is the potential for this to get infected. And if this gets infected, you're going to be in agony and septic and needing emergency surgery in 2 seconds. So that doesn't make any sense whatsoever at all. People should always have their fallopian tubes removed if they have a Hydrosalpinx. And like I said, having a Hydrosalpinx without treatment, it's a 50% reduction in your success.
Great information there.
There you
go. Love the drawing. Can you travel 2 months post successful FET?
Yeah, 2 months should be fine.
Can you have a massage during your 2-week wait?
Yes, you can. You can definitely have a massage. Just no deep tissue massage, and keep them away from your pelvis, obviously, but otherwise you're fine.
Do you offer NIPT testing for your patients?
Absolutely.
What company do you use and how much is it?
So we do. In Ontario, it's covered if the patients have a positive EFTS screen, so the early first trimester screen. It's covered if you're over the age of 40, and it's now covered if you have twins, and it's also covered if you previously had a trisomic baby, so trisomy 13, 18, 21. If we don't have coverage and our patients still want it, they can pay anywhere from $500 to $750 to get it done in Canada, or they can use Invitae through the US and pay $100 US. So we just use Invitae because it's ridiculous to do it in Canada for so much more.
Do you prescribe probiotics prior to embryo transfer?
Yeah, we do. So our protocol includes 5 days of antibiotics followed by 10 days of probiotics, leading up to the embryo transfer and sometimes even through it. Yeah, uterine microbiome, vaginal microbiome. I know some people are still arguing about this because they're not sure if it actually makes a difference. There is no way anybody could ever argue that the uterine and vaginal microbiome don't make a difference. There's so much data out there now. It's incontrovertible. Like it's crystal clear that it makes a difference. So you got to be paying attention to all of these details. That's how we got a nearly 100% success rate last month. So almost every single one of our patients got pregnant. So our protocol works for sure. Like we know it works because the proof is in the pudding.
Do you prescribe probiotics prior to the embryo transfer?
They just asked that.
Can you please talk about MTHFR gene mutation? How can it be tested?
It's a blood test for MTHFR mutation. So methyl tetrahydrofolate reductase enzyme is an enzyme necessary for folate metabolism. And you need folate metabolism in order to make DNA. So if you have a mutation, it means you're much higher risk because you're not going to be able to process the folate properly, which inhibits your ability to make DNA. So for patients with mutations, you either need to be taking folinic acid plus minus aspirin and heparin, or you're taking your chances. So we recommend for the patients that are heterozygous for MTHFR that they take baby aspirin and they take folinic acid. For the homozygotes, we add in the heparin.
What antibiotics do you use in protocol? What probiotic brand?
We use a Z-Pack just because it's easy. And probiotic, I mean, I don't promote one brand over another. We just happen to use NFH because my pharmacist liked it. But honestly, it doesn't matter. Any good probiotic with lots of lactobacillus is what you're looking for. I always shy away from recommending one product over another because A, we're not supposed to, and B, I don't normally think that there's that much of a difference. So don't get hung up on which probiotic you're on because honestly, there's no proof that one probiotic is better than another. We use one called Flora. I'm pretty sure it's from NFH. If it's not from NFH, it's from Natural Factors. It's a good product that's working for us. That's all I can tell you. But I'd happily support any other product that's out there.
Hello.
Hello.
Does T ever show his face, or are we to live with the mystery?
You're going to live with the mystery for now.
It's got to be a really good reason to reveal.
We got to have a good reason to reveal. Yeah, that's true.
I did intralipid IV last FET.
Okay.
Failed.
Oh, I'm sorry.
How to find out if it improved my chances otherwise? Is there a test to show results?
You can measure your natural killer cell activity. So Fertility does that testing. You can even get it tested here. You could look at complement levels. You could look at various immunoglobulin levels, interleukin levels. Like there's testing that could be done. So yes, there are markers that will show how to get information on whether or not it worked. It does work. I mean, that again is also incontrovertible. Like the data on intralipids is pretty clear now. So intralipids does benefit people.
Let the Instagram people know that our screen that read questions froze and I had to refresh. So some of the questions are.
Oh, okay. So if you're on Instagram, unfortunately, the program kind of crashed on us. And so just re-ask your questions because in the process of refreshing, we lost some of your questions. Sorry about that, but you can ask now and we'll focus on those ones.
Mhm.
Sure.
Thoughts on 2 low-dose aspirins versus 1? Also taking
Tinzaparin.
tenzaparin.
1 is more than enough. Don't take 2. You'd be a bleeding risk.
Who are interlipids indicated for?
Well, that's a good question. We use it for failures, like a previous embryo transfer failure. We use it in patients that we know have immune problems from fertility testing or any other testing. Some people would advocate for using it in patients with autoimmune conditions, so things like Hashimoto's or Graves' disease, or people with Crohn's or psoriasis or eczema, or anybody that's got any kind of autoimmune problem. So we use it in a variety of our patients. I've also been using it for many, many years for patients with recurrent pregnancy loss, because I think it actually works there as well. So yeah, there's a lot of different indications for it, but those would be the main ones.
Hello, Dr. V.
Are they back on Instagram?
Yeah, they're coming.
Okay.
I had a transfer on 4/6
Okay.
and just miscarriage on 4/26
Oh no, I'm so sorry.
with a tested normal embryo.
Yep.
I don't know what went wrong, but my doctor said the embryo collapsed, and I'm trying to understand that. I have to do another cycle that we'll do in the next couple of months. What would you do differently if I were your patient? I'm 32 with left tube removed and mild endometriosis.
Okay, so if your embryo collapsed, what they're talking about is something that happened before you even had your transfer. Am I still sharing?
Yeah, we can pull this back up.
Okay, so if this is your embryo, inside your embryo, there is fluid. There's a fluid component. And then there's the cellular component, which is over here. Oh, no, it's supposed to be in a different color, sorry. So there's the cellular component, which is over here. And this is the part that's going to become the baby. And then somewhere over there is the placental portion as well, okay? So that's going to be all placenta. So bottom line is, if an embryo collapses, it just means that whole thing went and shrank. So it's like going, whoop, and it all just shrinks down. And it collapses because the fluid probably drains out, or the whole embryo just kind of shrinks down. That is considered not optimal when you're doing embryo transfers. And it's probably related to either the quality of the embryo or how well they did with the development of the protocol for freezing and thawing of the embryo. In terms of what we would do different, I mean, if you have endo, I'd have you on Lupron and Letrozole for 3 months first, or surgery ahead of the procedure, like the transfer. And then we use a lot of supplements. So we use NAC, coenzyme Q10, resveratrol, and curcumin, all of which have been shown to be helpful in endo symptoms, not necessarily with frozen embryo transfers. But if it reduces your symptoms, it's undoubtedly reducing the inflammation, and reducing the inflammation is the key. So those are the things I'd be looking at. And then I'd also want to know why your embryo failed. There is a recent study that demonstrates that if you thaw your embryo in culture media that contains Neupogen, GM-CSF, the embryos do much better and the live birth rate is higher. So we've started doing that for our patients that have previously had failures also. And that stuff is crazy expensive, but I've been told we're doing it for free. So you're getting it for free from us if you're with us. We try and do our best for all of our patients without charging them if we don't have to. So we're taking a bit of a hit on those, but it's worth it because the success rates are incredible.
Uterine fibroid patient can take HCG injections for fertility?
Yeah, there's no reason HCG can't be used if you have fibroids. Absolutely. I can't think of why. Although HCG has never been shown to be helpful for fertility, so I'm not sure why you're taking HCG, but it doesn't have any impact on fibroids.
Is it true it's useless to do IUI with a sperm count of 7 million per mil? Total count 17 million, 2.5 was the volume. That's what the fertility doctor told us, that it's useless and we should go straight to IVF. I've heard that with 8 million, you could already do IVF.
I bet Tarek could actually answer that question, let alone me. So, no, it's never useless. I mean, you got to remember that the term useless is going to mean zero, right? So, zero would mean useless. So, is it zero? No, it's definitely not zero. Actually, I would need to calculate your total motile count. But if your total motile count is over 14 million or 9 million, depending on which study you're looking at, your results are normal. They're average. There's two big studies, and we've reviewed both on our show. So you can go back and look for those because we actually have those clearly labeled in our video series. So it's all up on YouTube. So if you're checking that out, you'll see that it's either 9 in the one study or 14 million in the other. So if you're at 7, but you got a total motile count that was, 13, 14, you're perfectly fine. There's nothing wrong with that, and that's considered normal. No fertility specialist should be telling you that it's useless because IUI is never useless. There are patients who have horrible sperm performance and still can make it happen because it might be 1%, it might be 3%, whatever the number is going to be for you, but it's still not zero. There's always a chance. If you can afford IVF and you have very significant sperm pathologies, yes, of course, it's a lot easier on you to achieve success by doing IVF, but I'm saying easier on you medically. I'm not saying easier on you financially. But if you can't afford the IVF, of course, try the IUI. I mean, what else is there to do, right? It's the next best thing, and there's no reason not to try it.
Hi, doctor.
Hello?
I had 5 miscarriage.
Oh,
Recently went for IVF, but one of the embryo tested for PGS. Diagnosed with chromosomes plus 10, 34%. Segmented chromosomal mosaic.
oh, okay.
Is it safe to transfer? If babies survive, what type of complications can have? Please explain.
So I'm not a geneticist, so I can't explain all of that. However, if it's if the embryo is a complete segmental mosaic for chromosome 10, so it's not plus chromosome 10 and then also a segmental mosaic, because those are two different things. So plus chromosome 10 would mean you have 3 copies of chromosome 10, and then also it's mosaic for something else. That's an abnormal embryo, which has an extremely low chance of becoming normal. So I would not advocate for putting that in unless you had to, because you don't have any more embryos and you can't afford to do it again. But if it's purely a mosaic, so the whole thing is mosaic, it has a 50-50 chance of actually being normal, and pretty much everybody is advocating for transferring those if you don't have access to making more embryos to see if you can get a normal one. So we would certainly support transferring that. We'd have no trouble transferring that. And because it's segmental, it actually has the best chance of working compared to the ones where the whole chromosome is missing, and it's mosaic for that. So segmental mosaicism is the best prognostic indicator for low-level embryo. You're at 34%, which is not low level because it's supposed to be less than 20, but you're also not high level, which is over 40. So it's hard to know, but it's certainly worth a try. I would not give up yet.
Ready?
Born ready, baby.
Thoughts on 2 low-dose aspirins versus 1?
Oh, they asked.
Oh.
You
Trying to
built
see.
me up and then you pulled the rug out from underneath.
You ready?
I'm ready.
What about Akai supplements for egg quality?
No idea. Should we look it up?
Told you.
Akai supplements for, you know what? Let me look it up on here.
I say sure, why not? All supplements are good.
Akai and fertility.
It's like pomegranate juice.
Yeah.
How bad could it be?
Pomegranate juice. Antioxidant intervention attenuates aging-related changes in the murine ovary. But where did they get it? Organic residues and biochar to potentially immobilize potentially toxic elements in soil from a gold mine in the Amazon. No. Oh, wait. Yeah, hang on.
I love your no yes.
Here we go. So there's one study. It's done by Bill Schoolcraft, who's a brilliant, brilliant, brilliant guy. And they are saying that in the ovaries of mice, it did demonstrate a benefit, but they've never done it in humans. So it could be okay.
There you go.
Certainly not likely to have a negative impact.
What exactly is the Letrozole protocol?
You take letrozole from day 3 to 7, and then you watch the eggs grow if they're growing. If you've been suppressed, you hopefully watch the lining grow. And you wait and see if your lining gets thick enough. If it doesn't get thick enough, then you have to add in a little bit of estrogen. If it gets thick enough, you can go ahead and start progesterone or trigger the release of whatever's there, and then go ahead and start progesterone. And then you do your transfer.
Do you always use a trigger shot? Do you use different amounts? And how do you know how much to use? Can they influence hormones differently in women?
So we normally use a trigger shot because there is data from one study that showed that even if you're ovulating on your own or surging on your own, you get a better success rate when you trigger. Now, there was older data that said that you shouldn't trigger, but we've actually dumped that and we have to get rid of that video. We do trigger for IUI. And then for IVF, you have to trigger because the eggs won't release unless you do, or they'll release all over the place without you knowing when they release. And so in order to facilitate the timing, you have to trigger. So these days, almost everybody is getting a Lupron trigger with HCG. And depending on how high their estrogen level is, we titrate how much HCG we're giving them. And it also depends on how high your LH is at the start of your cycle. If your LH is really low at the start of your cycle, the Lupron trigger will not always work, and you sometimes need a little more HCG. If your LH level is normal at the start of the cycle, you can probably get away with low levels of HCG. So if you have like a reasonable level of estrogen, we'll use 1500. If you've got a higher level, 1000. If you've got a really high level, 500.
What to do when prolactin is too low, 4.2 nanograms per mil on a range of 4.8 to 23.3?
Don't do anything about your prolactin. There's absolutely nothing to worry about there. If you're really worried, and Tara's going to start laughing, stimulate your nipples. It'll probably eventually raise your prolactin levels, but there is nothing else you need to do. And no one ever pays attention to low prolactin levels in regards to fertility outcomes. You can't have high prolactin levels, but low prolactin levels, nobody's ever even looked at.
What would you say is the ideal uterine lining for a FET? I'm currently 6.4 millimeters and transfer is possibly next Friday. Should I continue to be hopeful?
If it's next Friday, you got loads of time. So yes, you should definitely be hopeful. You definitely want it over 7. So you ideally want it somewhere between about 8 and 12. My embryologist likes 8 to 10. That's often hard to achieve, but 8 to 12 is decent.
What's the recommended wait time between ER and FET? Should we wait after a natural period or can start right away with the roof after ER?
With the roof? So you can go ahead and do your embryo transfer anytime after your egg collection. Obviously, most people will wait a month for you to get a period and then restart. There's only one study that I'm aware of that has shown any kind of difference in the outcome between the timing from retrieval to transfer. It's a pretty large Chinese study. It should be out now or is coming out. They actually suggested it should be done immediately the next month because the success rates were higher, but it's really hard to do that. So we usually put in 1 extra month of gap, and we're not seeing any downside to that.
I'm Letrozole protocol. What happens if you release multiple follicles before the FET?
Yeah, you got to be careful if your letrozole is stimulating egg growth, because it will actually wreak a little bit of havoc. So if you're getting enough stimulation from the letrozole to get your eggs to get multiple, like two or three, and they release, what's going to happen is you're going to get a very high level of progesterone. So you need to be cautious with that, because if you're also supplementing progesterone, you're going to get too much, and then you're going to end up with having birth control. So those are the cases where we're quite careful about what we do, and we make sure that we are not giving you too much progesterone, and we go up a little bit slowly, because what's going to happen is you're going to release your eggs and your progesterone level will slowly rise. So at the start it'll be low, but 3 or 4 days into it, it'll be sky high, and then you'll be quickly backpedaling on the progesterone you've given the patient. So you got to be really cautious with those cases. We try to avoid seeing the eggs grow by giving patients Lupron ahead of time. It lets the letrozole do just enough to make the lining thicken without seeing a ton of egg growth or development.
Thoughts on using letrozole for super ovulation? In addition, should you use progesterone after the IUI with letrozole?
We use letrozole for superovulation, although it doesn't tend to make you make two or three eggs, usually just one. And we do use progesterone for our IUIs as well, yes.
Taking tacrolimus for FET next week.
Good.
How can I ensure this is enough for immune issues? Other than blood tests timely, taking a chance at FET not knowing how I've responded.
There isn't an easy way without doing a mock cycle and getting someone to test. So there isn't a way to know unless you do a mock cycle and then do like either an endometrial biopsy or serum blood test, and then you got to send it off and you've got to see if it's actually working on what you're trying to make it work for. Do we have like a gajillion questions? Because
We'll do a couple more.
it's that busy.
Yeah, I feel like it's
It's
a little bit weird.
Okay.
Can you give a rough timeline for a typical dual stem cycle from start to finish?
Well, we now have two versions of duostem. We have normal duostem and we have split duostem. So normal duostem is do your normal IVF. So let's say from day 2 or 3 up to day whatever it takes, 14, 15 till you do your retrieval. And then you wait 5 days and then you restart the next stim, which can go anywhere from about another 8 to 10 days often. And then you do another retrieval and you're done your duostem. Split duostem is you do your follicular phase, so the normal one, and then we don't see enough eggs to do a luteal stem, or we think it's going to be difficult because too many of the leftovers from the last one have refilled, and now you can't tell which ones are new and old. So then we split it. We wait for you to have your period that month. We watch the next egg grow. When it gets to about an 18-20, we trigger the release of that egg with HCG. And then we go ahead and we start your stim a few days later, and we go and we collect that batch of eggs. So that's a split duostem because we're doing a luteal phase, but we're doing it in a separate cycle.
Having a laparoscopy to remove intramural fibroids and exploratory hysteroscopy.
Okay.
How long should I wait to do another transfer? Also, which protocol is best for a 40-year-old?
You should wait a minimum of 3 months, probably longer if you're having it done laparoscopically. 3 to 6, I would say. Which protocol is best? I mean, I can only speak to ours, right? Like we would recommend using ours. So a letrozole protocol, and then antibiotics, probiotics, melatonin, lots of supplements, vitamin D. Watch your lining carefully, vaginal and injectable progesterone. Monitor your levels.
Last question. 905.
Okay.
Thanks, fair. Unexplained infertility. 2 failed transfers of untested embryos. 1 miscarriage at 8 weeks with 3rd untested transfer. I'm 33 and healthy. Next steps.
Come see me, because unexplained infertility is a bit of a cop-out, right? So you're not truly unexplained until we've exhausted everything. And I'd say I don't think I've ever met anybody that had all the testing we do to figure out what's wrong. So in a case like that, I would say reach out to either your RE or us or somebody you trust and get them to figure out what's wrong before you do anything else. Because you're only unexplained if you've had surgery, you've checked for immune problems, you've checked for infectious problems in the microbiome, you've looked at your genetics, you looked at his genetics, you've tested his sperm DNA fragmentation, you've done a thrombophilia screen. Like, I could sit here for half an hour rhyming off all the tests, but you're not actually unexplained until you see that. So that's really important. And for you, definitely go check out our YouTube video on unexplained infertility, because it's critical to watch. Some things just don't work for unexplained infertility. So you got to make sure you're getting appropriate care and you're getting your questions answered. And there are a lot of tests that can be done to help figure out what's wrong. So I hope you guys had a wonderful, wonderful evening. We do have some super exciting news to share with you that should be out on Friday. Some of you may have caught wind of it already. So we will let you guys know there will be a big announcement for Windsor soon, and we'll let you know about that, and we'll probably be posting it on Friday as well. So stay tuned for that, and please don't inundate us with phone calls after the announcement. We look forward to seeing you guys next week. Next week will be on Tuesday again, and we'll see you on Fertility Fact or Fiction. Have a great night, and click that subscribe